During today's webinar, all participants will be muted. The audio will be streamed through the computer, so please make sure your computer speakers are turned on and off to hear today's presentation. So now we're going to review a few housekeeping items with everyone. If you notice that your viewer does not fit your screen, you can expand it by clicking the expand button located at the top right corner indicated by the red arrow right here. Now you'll see that your viewer is expanded to fit the entire screen. Also, you can collapse the GoToWebinar toolbar on the right of your screen by clicking on the small red arrow on the left of the toolbar. You can click the arrow again to expand, and the toolbar will expand. For today's webinar, as I mentioned, all participants will be muted. As we move through the presentation, if you have a question for a presenter, we ask that you use the chat box on the toolbar. Simply type your question and hit send, and we will pause at the end of the presentation so that we can answer your questions. Also, if there is not enough time to answer all of the questions, we will be posting the answers on our website. A recording of today's webinar along with the PowerPoint slides will be available at our website, www.attcnetwork.org/Hispanic Latino, approximately 1 week from today. You can also find recordings and PowerPoint slides presentations from all of our past webinars at the same URL. Also, one NADAC, one NBCC, and one ICNRC continuing education credit is available to those who attend today's live event. If you're interested in obtaining CEUs from these organizations, please email us at hispaniclatino@uccaribe.edu. Today's webinar is sponsored by the National Hispanic and Latino ATTC. As of October 1st of 2012, the network has been restructured and now consists of 10 regional ATTCs, 4 national focus areas ATTCs, along with the network coordinating office. As you can see by this map, the ATTC network regions were realigned to better fit the current HHS regions. And the 4 national focus area ATTCs are listed on the left. Today's webinar is the 18th in a series that the National Hispanic and Latino has been offering, and the second in a special series of EVPs for Hispanic and Latinos. The ATTC network is funded by the Substance Use and Mental Health Services Administration and serves a critical role in improving the health of the United States. The network achieves this by translating, disseminating, and promoting the adoption and implementation of evidence-based clinical practices and strives to improve the health and wellness of individuals whose lives have been impacted by substance use disorders. As I mentioned, the ATTC network is funded by SAMHSA. SAMHSA strives to reduce the impact of substance use and mental illness on America's communities through its programs and services, and demonstrates that behavioral health is essential to health, that prevention works, that treatment is effective, and people recover from mental and substance use disorders. Now I'm going to introduce our presenter, Dr. Omar Perez. Dr. Omar Perez obtained a PhD in clinical psychology from the University of Puerto Rico. He worked as a research assistant at the University of Minnesota and the University of Puerto Rico, working in research projects aimed at HIV risk reduction among injection drug users and under the supervision of Dr. Rafaela Robles. He was part of the research team that developed the Modelo de Intervención Psicomédica under the supervision of Dr. Rafaela Robles and sponsored by the Center of Disease Control. Dr. Perez was the director of the methadone program for the Mental Health and Anti-Addiction Services. He also worked as clinical psychology for the Intensive Outpatient Treatment Program at the Behavioral Community Clinical Center. He has offered services at various community clinics and agencies that provide services for persons with substance use disorders. Currently, Dr. Omar Perez is the Dean of Student Affairs at the Universidad Central del Caribe and Professor and Practicum Supervisor for the Masters in Substance Abuse Counseling program. He also offers trainings and continued education for the Northeast and Caribbean ATTC, among these trainings on motivational interview. So now I'll leave you with Dr. Perez, who's going to do the presentation. Okay, apparently we're having some issues with the sound, so we're gonna work with that, and you can hear Dr. Perez in a few seconds. There you go.
You hear me?
Okay, great.
Now? Okay.
Yes.
Let's go back. Okay. You hear me now? Okay. Okay, so as I was mentioning, sorry for the technical problems. As I was mentioning, the objective of this presentation is to describe the goals and objectives of MIP, as you can see in the screen. Also talk about the basics, elements, and key characteristics that have to be in place in order to implement these kind of interventions, and to identify the tasks needed to prepare for the intervention, and talk a little bit about the structures of the sessions that were part of this research. MIP is a comprehensive individualized behavioral intervention with the main goal of reducing HIV risk behaviors in IV drug users, but also other viral infections as hepatitis and some other infections. So it was very, very important, the approach that we use in the implementation of the program. We basically train all staff with how to implement comprehensive case management. So it's not just case management, it was comprehensive case management. So with the implementation of MIP, we dedicated an extensive period of time training all staff members in motivational interviewing, learning about self-efficacy, role induction strategies, stages of change, and some other very important theories, also cognitive behavioral approaches. So all the staff were on the same page in terms of the implementation of the model. Let me do something here that is not letting me see the screen. Okay, so the MIP was the target population that we worked with was basically people that were out of treatment, drug users, 18 years of age and older, and basically that were out of treatment for at least 90 days. The intervention, counseling, usually the period to implement the intervention were between 3 months to 6 months. It was depending on the accessibility of treatment, the stages of change of the participants, and some other issues that we had to, to deal with during the process. The intervention session, the intervention was composed of 7 sessions. And I will be talking a little bit in the future about the way we implemented the session, which was a very particular way. Okay, as we mentioned, the goals of MIP was basically to reduce viral infections, exposure, basically through behaviors, through injection behaviors, but also in sexual behaviors, and in drug treatment, and also all related health services. That doesn't necessarily mean doctors. Also, we had to deal with dentists and other very significant services for our participants. And the way we structured the session had the purpose to enhance participants' self-efficacy and skills to prevent relapse in drug use, but also to protect themselves in some of the behaviors that we were dealing with, basically sexual behaviors and injection behaviors. The original research was conducted by Dr. Rafaela Robles here at the university, and if you search for the research, the name of the original research is Effects of Combined Counseling and Case Management to Reduce HIV Risk Behaviors Among Hispanic Drug Injectors in Puerto Rico, a randomized controlled study. That is in the Journal of Substance Abuse Treatment, number 27 in 2004, pages 145 to 152. That's where you find the original research with all the results and everything if you're interested in having more information about the research. So as I mentioned before, it was for Latino men and women, 18 and older, residing in Puerto Rico. This research particularly took place in the central north region of the island. And at that time, we had close to, it was more than 500 participants, almost 600 participants that took part of the research. When we work with the project, what makes MIP effective was that when at 6 months follow-up, we found that the participants were twice as likely to enter drug treatment, which was wonderful, less likely to continue drug injections, twice likely to have increase in self-efficacy in a needle sharing situation. They were less likely to pool money for drugs, and less than half as likely to share needles. So all these behaviors are very important in terms of reducing HIV risk and hepatitis risk and other related conditions. What we consider and was considered to be unique in this project, when we work with the counselors and combine individualized counseling and case management, it was a very powerful experience because when working with this project, we went to the communities and we make an incredible bond with the community and with the providers in the region and with the other organizations that provide services at the community. So all staff knew services, knew the community services that were in the area, but also knew the kind of drugs that the participants were buying in different areas of the catching area and things like that gave us a very good idea of some of the problems that we're facing at the community level. The supportive interaction between the participant and MIP team was a very important factor because it was like that teamwork of the participant. At that time, we have as interventors registered nurses and also community counselors that were, we call them enhanced outreach workers. We said that they were enhanced outreach workers because they were trained in motivational interviewing, states of change, cognitive behavioral therapy, and social learning theories, and some other very important theories that helps the bonding with the participant. And also, they were not just taking the participants, for example, to services. They were also having an intervention during the trip, for example, taking them to the doctor, to the hospital, and everything. They were reviewing the interventions, and they were also talking about alternatives and evaluating stages of change, using the proper interventions related to MIP with those patients. So, and the other very special and unique characteristic of the intervention was the flexibility of all sessions. When we talk about the sessions, there were two fixed sessions. The first one and the last one, the induction session and the booster session. And we were going to be talking a little bit in the future. But it was very important because the sessions between were taking care of the health, reducing HIV risk through sexual behaviors, injection behaviors, and accessing detox services. Those sessions were based on the stages of change of the participant. I will show you very soon a scale that we use to evaluate the stages of change, and that we use to talk to the participant and evaluate the next session that they were interested in. So we reduced the participant resistance because they were willing and they were more interested in the next topic. As I mentioned before, there were many theoretical foundations that we based our research project. So we used the Transtheoretical model of change approach as Clemente, the social learning theory of Bandura, the role induction theory, the motivational interviewing by Miller and Rodnick, and cognitive behavioral approach by Beck, and definitely comprehensive case management. Okay, as I mentioned before, there were in terms of Transtheoretical model of change, there's 5 stages, and what is important about this is that if we have a participant that is in a pre-contemplation stage, for example, we invest more time giving information to the participant, working with the participant in terms of some contradiction or discrepancies in their lives, and working with the participants in increasing their awareness of the importance of identifying the problems with that behavior. So every intervention, the main for example, the nurses that were implementing the sessions, and also the community counselors, they were implementing the strategies related to that stages of change. So that was very, very helpful for the participant and to move forward the intervention. And also we were very aware that lapses and relapse it was part of the reality of changing the behaviors with this population. So we use every single experience of lapse or relapse as a learning experience. So we analyze the triggers, the risk, and help the participants overcome those experiences. This is a representation of what basically we were doing, and you probably saw this before. Some other trainings. When we were working with the participants, one of the things that were significant is that as part of the team, we have people that recover from addictions. That was also an example of overcoming addictions, and they were also helping very much the participant, and they can relate significantly with these persons, seeing that there were possibilities of change also. But at the same time, because of the bonding of the team, the nurses and the community counselors, they built a very big trusting relationship with the team, each participant. We have 2 teams of nurses and community counselors intervene with all the participants. So they became very comfortable working and seeing that relationship. So it was very important for the participants to see that the dynamics within the center was respect and collaboration and a lot of respect of the participants' need. Okay, one of the things that was extremely important for us is that the participant and the counselors know what their responsibilities were. So every time we work with a participant, we make them very, very clear what we expected from them. In every treatment plan, there's with the objectives, we know that the objectives are the responsibility of the participants. So for us, it was very important. Let them know that the achievement of the goals were depends very much in the efforts that they put also in the intervention. So participants were very clear what we expect from them, but they also knew the expectation they had from us. They knew that if they need transportation, we will provide a transportation. They knew if they need company going to a lab, we went there and be with them with the lab. So those clarifications were very important in terms of the implementation of the program. Okay, and let me see. Okay, let me go forward. When we work with the cognitive behavioral theory, we basically started working with this strategy when, you know, if you're working with MI, you have experience working with MI and states of change, you know that the earliest stages of motivational interviewing is not necessarily the best way to start using necessarily the cognitive behavioral approaches, even though you can start sharing some thoughts. But when the participants started acknowledging or identifying some possibilities of changing that behavior, some good things about changing the behavior, then we help them work with thoughts, feelings, and behavior, especially when in the session of relapse prevention sessions, that we make a lot of efforts analyzing the situation, where you were, with whom you were, how were you feeling, and analyzing every single trigger that the participant brings to the session, and to help the participant overcome the experiences of relapse or lapse. So this theory is very important, and when working with the participants, they identify those triggers and move forward. So working with MI, as we mentioned before, which is one of the main theories that we work here, it is a participant-centered counseling. So the main purpose is to evoke in the participants the reasons for change. So for us, working with the participant in resolving the ambivalence was the main goal, as is the goal for motivational interviewing. And we definitely didn't want to tell the participants what to do or give them specific directions. So we worked with the participant, analyzing with them and promoting analysis and decisional balances, and work a lot with developing discrepancy, so the participants can develop. I'm thinking in Spanish sometimes, so people, please give me that one. So we wanted to promote the intrinsic motivation, not necessarily extrinsic motivation. So that's the way we were building a very good intrinsic motivation is in our participants. As I mentioned, one of the things that we have here, the principles of MI. I am mentioning this because, for example, we dedicated more than 6 months knowing the community. That means we went every single day to the community. We went to the shooting galleries. We went to the different places they sell drugs. We get to know the person. We knew the key persons at the community, and we start providing things to the community. For example, we went to the shooting galleries. They allow us to put some information about how to clean needles. We provide clean cookers, water, chlorine, and we help them at that time with a lot of things. Also cottons, give them cottons, also antibiotics, and we were building a relationship for more than 6 months. So the people at the community were very clear that our purpose at the community were to help and to assist in every single way for the people to access treatment. So expressing empathy was part of, that process helped us communicate to the community that we really, really care. As I mentioned before, when we were working with the participant, developing the discrepancy is very important. Because of the nature of changing, we know that sometimes people are not necessarily ready to change, so we need to roll with resistance. And every time we saw that the participant was kind of hesitant to do a change, definitely was a message for us to change strategies, so we could help the participants engage in the treatment with less resistance possible. And the last principle, which is every time we definitely communicate to the participant that they had what it takes to move forward. And if we saw that there were other situations, we help as much as possible the participants to realize that they can do at least a single thing to start working through forward for the recovery. Okay, when we mention comprehensive case management, as I mentioned, we did a very important thing prior to the implementation of MIP. As I mentioned, we went more than 6 months at the community, but not also making relations with the participant, but also getting to know every single provider in the whole zone, meaning primary health services, services that were provided by churches, services that were provided by community-based organizations, services that were provided by municipalities. So we knew if a participant, for example, were living in the streets, we knew that taking that participant to an office of a doctor, the way he was dressed or the way he was projecting himself or herself could be a barrier if they go by themselves. So we make arrangements with, for example, the municipality. We went there, they give them the opportunity to have a shower, to cut their hair, or to shave, or to give them clean clothes. So so they feel more comfortable going to services. And other places that didn't have all that, difficulties, doctors, so they were accessible even though if the participant didn't want to take these kind of services. But at the same time, having a very specific mapping of the whole services in the area facilitated a lot the access of services. Okay, in terms of MIP case management, the team, the community counselor and the nurses at that time built an extremely good relationship with the participant. They were working together every time, coordinating the intervention activities. Every time they have an intervention with the registered nurse, after the intervention, the community counselor took the participant to the community. They asked about the experience in the intervention, how it went, what he or she learned, if they have questions, if they are interested in doing some other things, how they can help them, and also taking the participants to the community, help the community counselor to have interactions with their family or significant others, so we knew the support of the participant. So knowing the community and knowing the needs of the participant, we had the opportunity to advocate on behalf of the participant in a variety of services. For example, sometimes one of the experiences we had was with a participant that didn't want to go to treatment because they have a very bad, how can I say this, their teeth and mouths were in very bad shape, and they just didn't want to open their mouth to talk. So we coordinated services with a dentist, and we had to to help with the community, with the municipality. They provide money, so they make the, I don't know how to say it in English, caja de dientes, you know, the mouthpiece. So after that, the participant felt better. They went to treatment. They finished treatment, and right now she recovered from addiction. So we have to do a lot of things related to help the participants access treatment, and that requires a lot of sensibility with the community. Having a successful comprehensive case management is developing bonding, very clear goal settings, specific with the team, the participants, and also negotiating commitment with the providers to help this participant, and having very, very clear the task that we had to meet with the participant in very specific ways. Okay, as we all know, every intervention that is an evidence-based has core elements and key characteristics. So MIP has very critical components that have to be in place in order to provide, to be, I don't remember that word, to be, I thought faithful, I don't know, cuál es la palabra. To maintain fidelity to the intervention. Definitely, there are some core elements that I'll be mentioning, and there's some key characteristics that can be altered or modified in terms to the reality of the community, so they can implement it in a better way. So the core elements of MIP principle, is community assessment and outreach. As I mentioned, it's extremely important to know extremely well the community. As I mentioned, not only the places that provided services, but also the places and the different drugs that they were selling at the community, because sometimes a participant came to the office and just telling us where they buy drugs, we knew the risk that he or she were facing. The induction process, which is how we engage participants in participating in the project. Definitely the motivational interviewing and the techniques. So the training of the staff and the supervision of the good implementation of the techniques. By the way, all the interviewing sessions at that time were taped. So the supervisor were reviewing with the team the interventions, making recommendations, and training if there were more strategies to teach to the staff. The continued stages of readiness assessment. In every session, we evaluate the stage of change of the participants. So the participants were the one choosing the next step, and usually was in that topic that the participants were closer to action. So that way, we're lower the resistance of the participants. So continuous stages of change and readiness analysis is very, very important. The counselor case management community educator interaction is extremely important. We always were promoting discussion of the cases and preparation prior to the intervention with every participant. What happens at the community when you took the participant to the community counselor gave feedback to the nurse at that time and told her, okay, this person is having trouble at the community, or he has this community support or not. So that communication were very important, because the community counselor is the eyes in the community for the counselor. And definitely the flexible number of sessions and the sequencing and the booster session. The key characteristics here is cultural competency and sensitivity, team structure and training. So that will vary depending on the community that you were working with, the region, or in the state that you were. You have more Latinos. You have to be very cultural competence in order to provide a very good intervention. So counseling and testing for HIV and viral hepatitis. In this project, every time we promoted in the beginning of the session, if the participant didn't get tested for HIV, we promoted the testing for HIV and for hepatitis and other transmittable diseases. So that was one of the main goals also. So evaluating and have the opportunity for the participants to get tested, and that's also a choice for the program, and the MIT team interaction. So when working with the community, it's definitely we need to analyze the determinants of risk. So it was very, very important for us to note that motivation is a very, very important factor. The feeling of self-efficacy. If you have somebody that don't have the feeling that they can do or achieve recovery, it's very hard to work with a participant. There were skill building sessions. So when we were working with the participants, for example, in the injections session, we talk about the risk of injection drugs, but also we asked the participant the behaviors they had, if they were sharing cookers, if they were sharing needles, how they clean the needles and everything. And during those sessions, the nurses were teaching how to clean needles, were telling them how to, if you were going to continue injecting, the proper way of doing it, and so you can reduce the risk behaviors. That's why we also put knowledge, because we are providing knowledge to the participants, so they increase the awareness in terms of protective behaviors. One of the things that it was very interesting in the community is the social support system. In my experience, I am not saying that this is statistically different, significant, but in the community, as in my experience, women had more challenges having support by the community members, especially their families. They were more severe usually when they wanted to provide, because it was a lot of stigma. Women using drugs versus men, but we had the opportunity to work with all families and identify services that help us very much to help this part of the population, and also perceptions. Okay. When we were talking about choosing an MIP team, they definitely have to be very skilled and knowledgeable about drug using culture, because there's a lot of practices in the community. It is very important to know in every single detail the practices that the participant had in the community, so we incorporate that in the sessions. So in Puerto Rico, for example, they talk about caballo. I don't know how to say it in English, but it's when you pull money for drugs. So if you don't know what caballo means, you don't know what are the implications of that behavior, you cannot give a proper intervention. Or if you don't know the different names of the drugs or the mix that they use at the community, it will be very hard to help the participants. So also the sensitivity and flexibility of the team, they need to be very sensitive, and they need to be very empathetic with the participants. So the MIP team should be comprised of a program supervisor who have to be very experienced in MI, in stages of change, that need to know very well the community, and one counselor and at least 2 case manager community educators, as we mentioned before. In our experience, we have 1 supervisor, 2 counselors, and 2 case management at that time implementing the research. But with 1 counselor, you can probably work this intervention. As I mentioned before, the team needs to be trained in MIP, training of facilitators, not just the MIP. They have to take the MIP training of facilitators. We have an implementation manual and the two big folders that we work with the participant teaching everything on implementation, and I forget the name of the other one. It's the implementation manual and the I don't remember the other one, I'm sorry. So the training also have to be motivational interviewing, behavior changing theories with emphasis on transtheoretical model of change, community assessment, outreach, and field safety. That is extremely important because we need to guarantee the security of our staff. and also in cultural competencies. As I mentioned before, MIP characteristic, the staff, they need to have to be familiar with drug use and drug using culture, with HIV, STIs, and other viral hepatitis. Good communication skills. They need to know drug treatment modalities, not just the traditional detox services, but also all level of treatment available to the community. And in Puerto Rico, for example, there are some residential treatments that some people like, some other people don't like. There are some residential treatment that has medication within the treatment. There are others that don't have medications. There are others who let you smoke. There are others who don't let you smoke. So you need to understand every single modalities available in the community. And one of the things that we did, we have a menu of the treatment facilities at the community level, but we also ask for their reglamento, how do you say?
Regulations.
For their regulations, the principles of treatment that they have. For example, if a participant wants to go to a residential treatment, we show all the options, but we also describe in single details what they offer and what they don't offer. If a participant, for example, says, I am not going anywhere if they don't let me smoke. So we have, okay, in this place you can smoke, in this place you cannot smoke. So we have all that information also available for the participants so they can make a proper elections for the treatment. So non-judgmental attitude is very important, as we all know, and demonstrated professionalism to all sexual orientations. So when we work with community assessment and outreach, the community assessment, and I have been mentioning this many times, is knowing the epidemiological data, local and surveillance reports. We need to see the literature review, what it says about the proper way of doing this, performing this community assessment. We have to get key informants and interviews. Getting to know the community gave us the opportunity to identify people that guide us through the community and identify other key persons at the community who provided very, very important information in terms of safety, in terms of other places where the problem were. Also, the interests of the community, some needs of the community that we also provide for them. Gatekeepers interviews, focus groups, and field observations. Okay, so as I mentioned before, there were 7 sessions. The 7 sessions of MIP, the first one is a fixed session, which is an induction session, where we, to the participants, explain the program, provide the opportunity to get tested, give them pre-counseling, post-counseling of HIV, and introduce everything that we were going to be doing if they decided to participate in the program. So, and the session, that's the one fixed session, and as you see, session 7 is also a fixed session, which is a booster session. Sessions 2 to session 6 were flexible sessions. The first one is taking care of your health. In that session, and remember, in every single session, if the participant didn't get tested, we offer the opportunity to get tested. At that time, we used Oral Sure and Oral Quick, so we were working with the participants. In that session, we teach the participant what, if it's a woman or it's a man, in every single detail with what was health evaluation with the physician. So we teach them before, because sometimes they went to the physician and the physician didn't perform. It's hard to say this, but they not necessarily perform all was required for a physical examination. So we teach the participant, if you're a woman, you need to ask for this, ask for this, ask for this, and if you and you can also ask to prescribe this laboratory so you can know more your health. So we teach all participants what they should receive from the physicians. In session 3, which is readiness to enter in drug treatment, we talk about the importance of getting treatment, especially at that time where detox treatment and after detox treatment. So we were giving the participant the information of all available at the community and things like that. In session 4, which is relapse prevention session, we identify with the participant all the triggers or emotions and every single trigger that they identify in the past that could be a risk for engaging again in behaviors, not just for drug use, but also for risk for HIV and other viral infections. In session 5, which is session 4 to session 6, we call them like skill building sessions. So reducing drug-related HIV risk, in those sessions were a lot of practice. For example, we, as I mentioned before, how to inject drugs, how to clean needles, what you need to pay attention if you're pulling monitor drugs, that in that kind of behavior, so if you put more money and the other person have a dirty needle, so what you can do, so communication skills, and things like that. In terms of reducing sex-related HIV risk, also we gave them, for example, condoms, the proper use of condoms, negotiating in sex and other sexual behaviors that could put them at risk. We explained and gave them some models so they can practice putting a condom or things like that. So, and the booster session is a session that we review every single session, all the achievements. It's a session to validate or achievement in the program, to review with the participants what else is needed, and it's basically a session of reviewing everything and helping the participant to realize all the things they achieve. This is something that I already mentioned, so I'm going to skip this slide. This is what I mentioned before. In every session, we use this assessment form. As you can see, every column is one session. For example, going to health services, going to drug treatment, sexual conduct, and drug injection conduct. If you see from bottom to top, each sentence represents a stage of change. For example, in health services, I don't have any problems that I need to take care of. So that person, if they circle that sentence, that means that person in that stage could be in pre-contemplation. So we do that in every single session with the participant, and in those sentences that were closer to action, we offer the next session. So you reduce the resistance of the participant. Let me tell you something. During the implementation, we realized that, for example, if a participant says, I am interested in going to drug treatment, and we could make the coordination, and definitely the participant is going to go for a detox services, in that time we negotiated with the participants if they want to have the drug injection session prior to going to drug treatment, because we didn't want to expose the participant after going to drug treatment necessarily in an exercise of cleaning needles or something like that. That could be a trigger for the participant. So we also negotiated, if that happens, so we negotiated those alteration of flexibility of the sessions. So as we mentioned, we implemented the sessions specifically based on participant needs. It is very important to say that one session doesn't mean one contact. That means if you, as you know, if we're coordinated services, probably we need more than one contact in order to help the participants. Sometimes they need documentation, sometimes they need to go for an evaluation, and then they have to go for to receive the actual treatment. So so what I mean is 7 sessions does not mean 7 contacts. You could have a lot of contacts with one set related to one topic. So that depends on the accessibility of treatment and things like that. Okay. Okay. So this is the way you can see basically an implementation representation of the sessions. So definitely the fixed sessions and the possibility of going to the other sessions. It's just a representation of the implementation. So definitely MIP is an individual level intervention. And as I mentioned, I usually talk before this slide many things, so I am going to be a little bit redundant, but very important that depends on the need of the participants and the readiness of the participant. We are going to be giving more time to the participants to help them achieve their goals for each session. So induction and booster sessions also requires usually several contacts, but at least it lasts 45 minutes to 1 hour. So one of the things that I didn't mention that helps with this participant is every time the participants went to a session, we also provided them some, for example, we have some snacks there. We have juice or something. Sometimes that's the only thing they eat during the day. So they went there. We provide those things, snacks and things like that. We also have condoms available, cookers available. So the centers also became like a drop-in centers. When they need something, they went to the center and asked for things to the staff. And the other sessions usually took 45 to 1 hour in terms of the implementation. In terms of the theoretical part of the session, as I mentioned before, if you need to coordinate services, you know that it's that needed more time. One of the things that we did in order to develop self-efficacy with the participants also is, for example, when we were going to coordinate services with health insurance of the government, basically what's the health insurance that they had, is that, for example, we said, stay with me, let me offer get
Hello, we're
Hello.
connected. All right.
Okay. Sorry, we are having technical difficulties here. I don't know. I'm going to go a little bit back. I was talking about, I don't know about mouse. Okay. I was talking about the contacts that we need to have sometimes more than one contact with the participants. And I was mentioning, I don't know if you stopped hearing me, but what I was saying is, for example, one of the things that we did with the participant in order for them to understand how hard sometimes it's to coordinate services was that we talked to the participant and asked them to stay. During the process, we were calling to coordinate the services for an appointment, for example. And because it was made people, I'm sorry, this has been a technical difficulties. Again, I have to say it again. I don't know where I was when you stop hearing me, but let me try again. We share with the participant the experience of coordinating services, but particularly sitting the participant with us when we were making a phone call to make an appointment. And why we did that? Because sometimes making that phone call could last 45 minutes or an hour at that time. So when the participant had the experience knowing, oh, this is very hard to get this coordination done, they were less likely to not attend the appointment. So it was very important for us so they have and participate in the coordination of the services, because they knew how hard it was sometimes to get the services for them. Okay. As I mentioned, each counseling session was followed by case management. So basic health and human services were provided, motivational through the process all the time. Obtaining the necessary social and family support was very important, coordinating at the community. And as we mentioned, the time frame for the implementation usually was between 3 to 6 months. The structure of the sessions, we encourage the testing for HIV and STIs. We encourage the participant to use the healthcare services, including drug treatment, ensure social support, provide referrals to the community, document all single contacts, including everything that we provide to the participants. If we provide cookers, condoms, everything, we recorded that, everything that we assisted the participant with. So we utilize motivational interviewing techniques, and as I mentioned before, we offer beverage, snacks, condoms, cookers, cotton, antibiotics, and they went to the office and they became like a drop-in center for them. They were very comfortable going to the office and asking for those things when needed. Interaction between the counselor and case manager is extremely important, as I mentioned before, and the bonding of the staff. Also incorporating the participant in that discussion with both of them. I think we're done. Yeah. Okay. Does someone have questions or?
Thank you,
Thank
Dr.
you, Dr. Perez.
We have a few questions. Can everyone hear me? Okay, we have a few questions. We have one person asking, how did the community that you were working with welcome the project, and were there some challenges to overcome to gain acceptance?
I'm hearing you echo.
How did the community that you were working with welcome the project, and were there some challenges to overcome to gain acceptance?
Okay. Do you hear me? Do you hear me now? Okay. Yeah. So community were very, very receptive, because at that in the north central north region of the island, there was a lot of need of treatment, especially for people with addiction problems. So they were very protective to us. Even every time we went to the community, they helped us, they welcomed us, and they also help us have connections with people with the shooting galleries, also the people who were selling drugs there. So they knew that the purpose of the project were to provide services. And because they knew that we have contact with community-based organizations, faith-based organizations, municipalities, and it was also related to a university and a school of medicine, they were very, very receptive. And also they were very protective. If something were going to happen at the community level, they warned us and say, okay, today is not a good day to go to the community, for example. So they were very receptive, very protective, and also because we were providing since the beginning information, posters, cookers, and we also talked to the community. Actually, we talked to the police in the region. We talked to the mayors. We talked to the people in the churches, knowing that the purpose of the project. So we went to every single community agency and to present and to describe what we were doing at the zone. So it was very receptive.
Okay. Someone asking. What specific municipalities did the project take place at?
Okay, in the north part of the island, we were working in Vega Baja, especially a place called Altos de Cuba. It was where we have our office right next to the plaza, to the church in Vega Baja, but we were working from Manatí, Vega Baja, Toa Alta, if I'm not wrong, all those regions. In Puerto Rico, when there was some intervention of the police, sometimes those central regions were very affected by addiction. So there was a big movement to people to the mountain and to those municipalities. So as I mentioned, we recruited almost 600 patients in Vega Baja. They were coming also from Manatí. Most of them come from Manatí, Vega Baja, and the central region.
Okay. We have another one. What kind of harm reduction kits and snacks would you recommend to chronic homeless?
Okay. Let me tell you,
I am not a nutritionist, but I can say that at that time we have some cookies, we have natural or juices, and we also make connections with other communities, with other community-based organizations that provide those kind of things to them. So that is something you don't have to directly provide. We always, even though we have things there, they were simple things, cookies, some sweets, but juices, water. But at the same time, we make coordinations with community groups that provide, for example, municipalities that provided food and things like that.
We have a couple more questions. But what we're going to do is that we're going to post them at our website so that our participants can have access to the answers. Okay. So at this time, I would like to thank Dr. Omar Perez again for taking the time for doing the presentation. And also, I would like to remind the audience that a recording of today's webinar and the PowerPoint presentation will be posted and available at www.attcnetwork.org/.